Saker. Dr. Saker, I'll hand it off to you if you can just share your screen.
Thank you, Rachel. We really appreciate the invitation and the opportunity to speak to our community as well. And thank you so much for the kind introduction. If I may preface by saying that when I was asked by you kindly to present, I envisioned that the attendees are from the public. So try to keep in mind that sometimes when we give a lecture to an audience of dentists and or surgeons, they have a lot more advanced dental training, and they have, you can talk about certain concepts casually, and you assume everybody understands it. So I try to put this lecture together as if I'm doing a consult in my office for a patient who's coming in to see me to speak about dental implants. So we try to hopefully make it understandable, speak it in lay terms if possible, just for the sake of clarification. And if there's any questions regarding certain concepts, by all means, I'm more than happy to answer. So today we're going to talk in general about dental implants, go through maybe a brief history of the concept of a dental implant, how does it work, why dental implant versus other options, what are the alternatives, what does it do, what is it made of. I'm trying to answer questions that I'm asked every day. Hey, how long does it last? How should I care for it? Can I get a dental implant or not, et cetera, et cetera. So we'll go through that hopefully, and I'll be able to shed some light on most of those concepts. So the lecture objective, again, what is a dental implant, the history, the components, the materials, the considerations, why would not, indications, contraindications, and benefits versus risks and alternative options. How do we get to the diagnosis? The imaging involved. Part of the lecture, if we have enough time, we can talk about the most recent advances in the robotics now in dental implants as well. That I will just say that it's in the infancy stages, but it's very promising. And then post-operative care and complications in managing those. To start with, I guess the question is, hey, what is a dental implant? A dental implant, I want you to think about the anatomy of a natural tooth. If you look at the screen, the slide on the screen right now, you see that metallic object, that's the dental implant. I find a common misunderstanding by the public. Their thinking is the porcelain top of the tooth, and of course, understandably so, because that's the portion that the patient perceives as that is the implant. And the answer is no, the implant is the titanium or metallic root that is going to replace, if you look at this picture here with that implant between teeth, your roots anchor up into your jaw. Your teeth anchor up in your jaw with roots, and that's the foundation. And that's what gives the tooth its stability. It's the bigger bulk of the tooth itself. And on top of that, above the gum line, is what a person feels, sees, perceives, is the dental crown. That's the anatomy of the tooth. You have the root, you have the crown, and inside the internal part of it is the chamber or the canals. And people hear, oh, I had a root canal therapy. That's when a dentist goes through the tooth and retrieves a dead nerve from the canal and obturates it. A dental implant usually is made of metal, and there is a lot of materials that can be involved in the composition of an alloy. However, the most predominantly used metal is titanium. It's extremely biocompatible. It is not as expensive as you might think, but there are, they mix it now with alloys. Titanium in its purest form, it's about 40% stronger than steel. In an alloy form, it could be twice as more stronger than steel itself. But the concept of an implant is that this metallic portion right here, it is a replacement of your root, and you're implanting that part of something into your jaw, and that is the implant. The top portions, and we'll talk about the anatomy of the implant in a moment, is the crown. A little bit history on that. The ancient, probably the oldest one we know is the Egyptians in from their cadavers or mummies. You'd find them crafting a tooth-like structure and hammering it into that socket where this patient had teeth, and try to replace a dental structure. The concept is not dramatically different from a concept. Of course, the technology is a lot more advanced, thank God. And the Mayans as well, there's evidence of similar attempts of replacement, whether it's superficial and tied together with wires, or it's hammering an ivory object into the area into a socket of the tooth itself. And then we move into the more modern era. Dental implants as we know them today, even though used by dentists or the dental community, by oral surgeons and periodontists and general dentists, and etc. The dental implant was designed by a Dr. Ingvar Bernmark, who actually is an orthopedic surgeon. And Ingvar, Swedish surgeon, noticed that using that titanium, when they use plates and screws to fix somebody's fractures, they noticed that those objects are hard to take out. In Europe, they tend to go back and remove the hardware from a fracture, not as commonly anymore, of course, but in the US, we kind of tend to leave them be because they become part of the body, and they, if they're not infected, you leave it alone. But when he had to go back and remove some of the hardware that was successful, not infected, he found that those things are very hard to take out. And he looked at the concept and realized that, this titanium is extremely biocompatible material. It must have been, he could have been that ancient pharaoh that needed a tooth, and thought about why not develop something that could go into the bone, that's made of a titanium, designed like a dental tooth or root, to replace that structure. Intelligent concept, use this basic scientific and surgical knowledge to develop that for all of us, which is wonderful. That was, the first implant placed by him in 1965, again, even though he's an orthopedic surgeon. Then there was a lot of research and development on that topic. Those implants were placed only in academic institutions under research and for development and understanding and cadaver dissections and studying under microscopes and how the thing's working. Became very solid concept, had a lot of success with it, and then became commercially available in the United States. I believe the first commercially placed in a clinic and dental implant was done in 1986. Became a really the concept, revolutionary concept in dentistry, late 80s and most specifically early 90s. As Rachel said, I graduated UPenn in 1994. And I do remember very clearly that we actually had the implant suite where surgeons were being trained to do implants, was the Brennemark suite. It was the only implant in the market. It was the implant in the market, in fact. Now it's changed from Brennemark to Noble Biocare, and there are other companies that walked into the field and did some marvelous advancement of that dental implant, and whether it's in the type of metal or the shape and design and the restorative components that surpassed actually that original, the golden standard. But in history, historically, that's where it came from, and we'll talk a little bit more about where we are today. The anatomy of a dental implant, as you can tell, in the center of that screenshot, you have, again, look at that's the osseous structure, that's the bone, that's where the jawbone would be. That's the titanium implant. It's the titanium body that goes into the bone. The bone integrates very well around the implant itself. And we'll speak about design in a moment and how does actually bone grow around and gives this implant its great stability in a moment. But once this implant integrates, and it usually takes anywhere between 8 weeks to 4 months, and it sometimes could be longer. It depends on the bone density itself and the bone volume. But assuming you have plenty of bone and it's nice and dense, it's anywhere between 2 to 3 months after the implant is placed. It's, again, go back to the roots of this procedure. It's an orthopedic surgery. Someone was to break their arm or their leg and a bone in their body, and an orthopedic surgeon goes, puts it together. They put titanium screws on it. They say go light, function on it for 6 weeks, and then physical therapy, and then you progressively load that limb, and then in 3 months, you have good strong bones. Your bones heal together. They calcify well. They ossify. They pick up their minerals, and that bone becomes strong enough to be used normally. And the implant is not that much different. There's a lot of research in the last 15 years, 20 years, coming more than 15 and 10, trying to design, manufacture implants that can heal faster, meaning, the implant is ready to have a tooth on it in 6 weeks. And while that concept is challenged where, one might say it has initial stability, we know microscopically it probably requires a little bit more for that bone tissue that forms around it to mature and become stronger for, permanent loading. Then after the implant heals, then the components that the patient has been waiting for, this is the foundation it needs to set, comes, and that becomes the restorative part. Everything above the gum line, a patient goes to their dentist then and have this part here that's called the abutment, and it comes in so many different shapes, and there's a lot of stock abutments, but there's more commonly, and what should be used in most of cases, is a custom abutment. So the dentist usually takes an impression for the patient's dental arch and the opposing arch and send it to a lab, and the lab will custom make an abutment. That is the portion that goes and inserts inside of the implant. And there is a screw that binds, go through the abutment, go through the implant. It's almost like a lag screw that binds the two together. Again, those screws usually are made of titanium. They have a microsurface to them. They have a certain, they're made in a certain way where for those who had dental implants, you hear that the dentist torque the abutment on the implant. It places that screw inside the implant with a certain torque force. It's usually tested and calibrated by the manufacturer, but usually about 30 to 35 newtons per centimeter. And what that causes, it really locks in that screw inside the implant. It causes a little bit of not a deformity as much as it causes that screw to expand out microscopically and cause what's called a cold welt. So that implant now is stable on that implant. It becomes not a part of it, but it's almost an integral part of it. And the crown then usually made of either zirconium or porcelain, or there's a lot of materials, but conceptually it's a porcelain crown that fits on this abutment perfectly as well. The crown is custom made by ceramists to fit over the abutment that's custom made to fit over the implant itself. So you have the implant again, you have the abutment, you have the screw that binds the two together, and then the crown that goes on top of it. A little bit of variation of that. One would ask, like, how do you put the crown on how do you stabilize this crown on this abutment? Like you would on your own natural tooth when you get a crown. So the dentist will put some cement inside the crown and quote unquote glues it on the abutment. However, we hate to see any of the microscopic material leak through that into the tissue because that causes inflammation, and inflammation causes some gum recession. So what most people, if possible, for back teeth, the dentist will create this abutment and crown piece as one piece together. And the crown will have like a little chimney on the top of it that introduces that screw. It's one piece. It's placed on the implant. The screw is torqued, and then they seal the top portion of the crown itself with a cosmetic white filling. So this way, there's no introduction of any excess material at this area, or it's called a dirty gap, to cause less inflammation, less gum recession. So it's more hygienic and more cosmetic, but it's not always attainable. That is not as easy to do when you have your upper front teeth because they go on an angle, and if you go straight into that implant, it would cause that access hole to come through the face. So that's, depending on the anatomy of an area itself, usually. But that's the anatomy of an implant. The function and the purpose of the implants, again, as we said, this is a foundation of the foundation that you're gonna put inside the jawbone to replace or hold a structure. If it's a single tooth missing, then it's a single crown. But you have the other side of, somebody has terminal dentition everywhere in their mouth. You don't put in a single implant to replace every single tooth, but then you create, let's say, 6 to 8 implants in the entire arch, and the dentist will create a structure of set of teeth that actually can go and attach to the implants, and that's what's called fixed dentition. Sometimes, the patient requires or wants a denture over implants. Dentures tend to have a lot of mobility with them, especially over time, especially with people that don't have enough bone structure in their mouth, because they gain their stability from suction and or stability on the jawbone itself. For those patients, especially for lower teeth, sometimes it's as simple as placing 2 implants on the lower jaw and the bone, and then have that denture snap on the implants, or maybe 4 implants, and have that denture be screw retained. When patients ask, like, hey, what do you think? My job as a surgeon is to lay the foundation for the dentist. I always say, if you want to build a house, we don't start by, what color are we going to paint it, or, what kind of shell you're going to put on it. The question is, hey, what's the blueprint like? The surgery should be driven by what's the ultimate design of the restorative choice by the patient, supported, of course, by the dentist and the surgeon themselves. So that's the function. Always think about the function of the implant as a foundation for a restorative component that needs to go on top of it. Shapes, as you saw, it could look like a screw, and that cylindrical screw surface is what gives the implant what's called its initial stability. But actually, the feature that gives us its longevity and stability for future is the surface itself. A lot of times these implants, when they're manufactured, they're placed on spinning structure, they're spun fast, they're sandblasted. So when you look at an implant surface microscopically, you see a lot of small pits and fissures, and these create more surface for the bone to grow into, and crevices, and that's really how the implant and bone interact, and that's what gives the implant more of its micro stability. The surface of the implant itself is probably what has changed and gave probably the part of implant design that has advanced the most in the last 15 years. And we find that different surfaces have better biocompatibility and would allow for better healing and faster healing. Had a lot of types, cylindrical, fixtures, would look like a little tube. Believe it or not, we placed those in the past. Haven't seen one in a long time, but you used to actually, drill a hole into the bone and, your implant size, and you just tap it, hammer it in, just like the Egyptians did 3,000 years ago. Um, Rarely is the case today. Just want to make sure that we address a little point of implants. Um, a purpose for or function that is not commonly seen by patients is somebody that has a massive car accident, they lose part of their face, or cancer resection, they lose part of their face, and a maxillofacial prosthodontist is replacing that part with a prosthesis. Dental implants are placed, they're implants. They're calling dental implants anymore, just they're implants. They're placed into the skeleton or the skull in this case in specific areas to hold that prosthetic that can help somebody to replace part of their face or their jaw. As far as dimensions, they come in every single imaginable size and width and length. Width was an issue in the past because that material has to have an internal part to take the abutment and the screw, and you had to maintain a certain thickness, otherwise the structure itself was split. Now with the advancement of different alloys that are much stronger than just raw titanium, they're able to design much narrower implants for areas that have would need to replace smaller teeth, like the front lower teeth, as an example. Abutments, that's the part that goes on top of the implant. These are examples of, stock abutments, such as this one here and this one here. These three here probably is what's used on overdentures. These are used for full arch cases. These are used in the front. They're made of zirconium, but these are custom made. So there's a lot of designs and a lot of materials based on, the purpose of that. As you said, titanium, zirconium, or could be gold. Gold is such a standard, extremely biocompatible material, but it is not used as often today for cosmetic reasons, and of course, the obvious reason, it's extremely expensive. The expense tend to be cost prohibitive. We see some patients from the older dental era that come in with a gold in their teeth, and that was placed 40 years ago. It's an amazing material, but you don't see that often anymore these days. But dental material is so advanced as well that offers a lot of great choices as well. We spoke about the abutments and their placement, the aesthetic, the function consideration. If somebody's getting a front tooth done, the implant is placed at the bone level, but the abutment comes from the implant through. So a lot of times the dentist will choose to put a zirconium implant, and even those zirconium implants, instead of them being so white, now they're manufactured for the color to be a little bit on a pinkish hue. So if somebody has what's called a thin biotype gum that might show through that material, it's going to look so natural. So there's a tremendous emphasis today, not only on function, but on cosmetics. So back in 1989, we just hoped to put an implant and it sticks. Today, we know we can get that success rate in about easily in 98% success rate. We pay a lot more attention to the soft tissue, the gum shape, the gum type, the emergence profile, the crown. There's a lot of detail that actually takes place. I just want to make sure that I don't mislead anyone, but I am an oral maxillofacial surgeon. I do only the implant surgery. I trained well to restore them, but in the state of New Jersey, once you become a specialist, you limit your practice to specialty. The only crown I did in 30 years was my mom, because she insisted. She helped pay my tuition. So, but usually we do the surgery, place the implants, make sure everything is proper, and then we send the patient back to their dentist to put their crown on, and they do that every day, and they're really good at it. We spoke about custom made versus standard abutment. Standard abutments tend to be more readily available. They're fast, they're there. You can just buy it and get it in and done, and they're cheaper to buy. by the dentist. However, we find that they don't come with great stability features. So there's a lot of design when the dentist design those things. Um, they have to create certain angulations and there's a lot of science behind, how tall, how many degrees you bring it in, etc. Back in the days, we used to have a technician custom make it from wax. They literally would just get and craft it from wax and do a burnout for the metal. Today, almost everybody is doing computer design. You scan the implant. It's you design it on a computer. You precisely dictate the degrees, the height, the emergence, everything, and then it's just custom made, custom cut by a machine to what you want. It's really phenomenal how much dental technology had advanced in offering things that are really functional, strong, and pretty. That's again the crown concept, the implant, the abutment, and the crown. We spoke about that. Spoke about the function. The crowns, dental material, I honestly can't even keep up with the dental material. That is a topic of restorative dentistry, but the predominant materials that cover the metal are, porcelain, zirconium. There are differently hybrids of materials now combining the two as well. Depending on, let's say somebody is a clencher and they're going to break that porcelain, the dentist might design the chewing surface to be metallic and maybe the covering surface, the visible surface for cosmetics to be, porcelain. But these are really patient specific driven based on the rest of the dentition itself. Impression is done, it's fabricated, it's glued in, it's cemented, it's a single crown versus a bridge. Longevity and care, very common question. Hey, how long is my implant going to last? And there's really the ethical answer is it will last as long as you can take care of it. Can a dental implant fail? I will tell you that 3,000 years from now, when archaeologists unearth our skeletons, like we do for, and in archaeology, they'll find the dental implants and our bodies will be decayed around it. The material is very stable, but it's in the oral environment. It's exposed to harsh oral environment and bacteria and plaque and food and traffic. And so as long as the bone surrounding the implant is there and the gum is healthy, the implant will always be there. What fails is not the dental implant. What fails is the structure around the dental implant. It's the patient's gum and bone. Classically, those things could theoretically last forever if they are cared for properly and they're maintained properly, and the patient goes back there for hygiene appointments and they're doing good follow-ups and cleanings and they do their homework and home care with flossing and water picking and brushing, etc. And there's no dental infection or gum infection around the implant. There are minor exceptions to that. There's no reason for it to fail. Clarify the minor exceptions is that now there are classes of medications and drugs that affect bone viability, including bisphosphonates that are given to patients for osteoporosis. So we find that those on their own cause bone failure, not just around implants themselves, but around teeth as well. It kind of becomes one of the contraindications if patients on the injectable bisphosphonates. There's a white paper. If you go to American Association of Oral and Maxillofacial Surgeons, type white paper by aaoms.org on that, and you'll read it. But there are some. So it's not a failure of the implant. It's not a failure of your hygiene. It's more of a failure caused by a side effect from a drug that a patient is on, maybe for a bigger issue. But otherwise they can last. Can they last 10, 15 years? Absolutely. Can they last 20, 30 years? Absolutely. I've been in private practice in this very location. I'm going on 26 years now, and I don't see my patients come back, but maybe a handful a year. with failures. Classically, there's either, not good follow-up with hygiene, and it failed, or they have uncontrolled diabetes, and everything is failing, not just, their dentition is failing and their implants their bone around it is failing. So they can last for a very, very long time. So what I type here, lifespan of 15 years, it's probably derived from when you look at a dental insurance company like Delta Dental and says, hey, I'll replace it every 7 to 10 years if it fails. But the lifespan of those implants should last a lot longer than that. It can last a lot longer than that. An example of what dental implant design is, and again, you can tell like little subtle, like the holes inside here is just for bone to grow through it as well to give it stability. That internal part is where the abutment sits. This looks like a hex, which is the more common design. There are different designs for that too, and then that internal shaft is to accept that binding screw. Material is predominantly titanium. Today, you'll find probably the top 5 largest implant companies, most reputable implant companies in the world that use titanium alloy. I will take an example of a company called Zimmer, and I have zero financial attachments to any dental company or anything outside of my office, by the way, so I don't take royalties from anyone, for disclaimer. But Zimmer, which is the largest orthopedic company in the United States, uses titanium at 92%, vanadium 2%, aluminum 6%, extremely stable and strong alloy. A company like Straumann would use 85% titanium, 15% zirconium. Company like Noble Biocare, that was Brennemark, again, it's another alloy. So they found that alloys are stronger than just pure titanium, and that's what's being used today. So there's a strong titanium component to the dental implant. There are exceptions. People who are allergic to metals, and we get those maybe twice a year, and then they say, I'm allergic to metals, and can I get a zirconium implant? And the answer is yes. However, your possibility of being allergic to titanium is probably in the 1 or 2 per million. And why not zirconium? Zirconium is strong, but the design of today's implants, this is not to say what 15 years, 20 years from now, it's not going to change, but today's design of those zirconium implants does not allow for the versatility and the size and shape of the regular titanium implants. It's a lot more developed. So it has a lot of limitations to the design and your choice. It makes it very limiting to where you actually can use it. So I advise my patients, if before we throw a statement like, hey, I think I'm allergic to, go to an allergist, get tested. Here's what the implants are made of. Usually 5 to 6 metals are usually what make most of the component, the alloys. And if you are allergic to, then we avoid. If you're not allergic to, let's go. So in general, strength and durability, corrosion resistance, they don't decay, they're very stable. They don't unleash, any material into the bloodstream or the jaw. Alternatives, as you said, zirconium, the zirconium, titanium, stainless steel. Calcium phosphate is an orthopedic, again, comes from orthopedic literature as well. It was very popular back in the early to mid 90s, but and it's an amazing material that the bone loves. But there was a separation, micro separation between the titanium body and that surface of calcium phosphate. And when those implants, had that micro separation, that's a mechanical failure of the implant itself. Then there was great failure of those implants. So you rarely find that to be used in today's world anymore. Indications we spoke about. So you're missing a single tooth. Here's a single implant. You do that. You're missing multiple teeth. Let's say 4 teeth in a row or 3 teeth in a row. You don't get 3 implants necessarily. You can, with exceptions. Again, to manage cosmetics of soft tissue, but usually can get an implant, 1 in the front, 1 in the back. You have a 3-tooth bridge. People come in with completely terminal dentition. I mean, they have every single tooth in their mouth, and they had bad circumstance or bad dentistry or bad hygiene or whatever it is that led to their failed terminal dentition. So you replace the entire arch, and again, you don't replace every single tooth with an implant, but you design it so that you can lay a foundation, and then the dentist could put something on it, whether it's a zirconium bridge that is attached to the implants that doesn't come in and out, or was it a denture that, an overdenture that clips on and clips off, and you can take it out and clean it and use it? Of course, uh, indications are different. There becomes a lot of factors. Do you have the bone to do it? Are you healthy enough to get those surgeries done? Or do you have the money to do those surgeries? And there are a lot of factors that play a factor into the choice of and what for. Contraindication, do you have enough, not as much bone density, even though that's true, as much bone volume. Overall health, I mean, patients come in, they smoke a pack a day, and they have uncontrolled diabetes with A1C of 8. Not a good candidate for implants, because you're going to do that surgery, it's going to fail. You're going to do any surgery, they have a high risk of failure. Their wounds don't heal well. They get more prone to infections, and they have their vascular structure is not as good, and they don't form new vessels, and et cetera, et cetera. So what you do with that is, hey, you can send it back to their internist and endocrinologist, get them tuned up and get their diabetes under control. They're, stop them from smoking, and then proceed with those surgeries. Um, Definitely a controversial topic. Is smoking a contraindication? The answer is no, it's not a contraindication, but smokers tend to definitely have a higher failure rate. Meaning, you take a group of smokers, you take a group of non-smokers, you do 1,000 implants here, you do 1,000 implants here. Probably be 990 of the non-smokers implants take, and they're great. Probably be 800 of the smokers will probably have implants that take, and 200 don't. So you have a definitely effect on, it's all about healing. And is your body able to heal itself or not? And that smoking affects locally with nicotine and systematically with poor neoangiogenesis. Uh, Oral hygiene is huge in our world, where we always say, if you give you the most beautiful set of implants, and you can get a most beautiful set of teeth today, but if you don't take care of them, you will show up with all those teeth in your hand, 5 to 6 years later. So somebody has poor oral hygiene, you try to first monitor and get them into a program, and you see that they actually are committed to that, and you start progressing to then. Benefits, again, to hold a single tooth, multiple teeth, full arch. We spoke about that. A bridge versus a dental implant. It's probably not my most accurate slide. Probably was doing that at midnight. But the concept here, hey, if you're missing 3 teeth here, you can get an implant on each side, and then the abutment and a dental bridge on it. You can get a dental bridge on your, let's say, assume that's your tooth and it's ground down. But if you're missing 1 tooth only and you have 2 natural teeth, it's better to have an implant done in the middle than have to grind these adjacent teeth down, assuming you have the structure for it and you're a good candidate. So pros and cons. A bridge hey, you're missing a tooth. Can I get a bridge? Absolutely. Is that a good treatment plan? Absolutely. It's been done over 100 years. Why not a bridge? Why an implant? Well, an implant, you can just put an implant here. It gets its own crown. You're not filing down these teeth. You leave the adjacent teeth intact and virgin. And you put your implant, it functions independently. You can floss in between. Well, how come not everybody gets an implant then? Well, the bridges can be done faster, so you're not waiting, for the tooth extraction to heal and the implant to heal, 3 to 6 months, whatever your condition is, and then initial cost could be, favoring more towards a bridge rather than an implant. And on that topic, if you're replacing a single tooth with a 3-tooth bridge versus 1 implant, last study that I read by a dental economist said actually that the implant would probably be about 15%. This is somebody's paying for those out of pocket. Put the insurance world on the side here for a moment. I can't get into that. But if a patient is paying for a dental implant versus patients paying for a three-tooth bridge, last, again, dental study that I read was like an implant is about 15% upfront cost, more expensive, but it is about 35% less expensive long term. And when you dig a little bit more into that study, it shows that bridges, sometimes they have recurrent decay, they have to be replaced more often than dental implants, and that they need root canals, and implants don't need root canals. Be able to maintain a dental implant better and be able to hold on to that structure for longer. You're not violating the adjacent teeth. So the pros and cons, dental bridge can be done faster. It's a little bit cheaper up front. Hey, it's a go. I don't need surgery, but the implant can last longer. It feels better. You can maintain it and a better hygiene. And long term, it actually could be less expensive. We spoke about that. Again, preserve adjacent teeth. The pros of dental implant: durability, longevity, bone preservation. Bone preservation is a very interesting concept. Think about your workout. Like, hey, somebody again breaks their arm. One arm is in a cast and the other arm is not. You take the cast off 3 months later, 6 weeks later, the arm that's been casted, that's not being used, exercise, that muscle atrophies. Bone atrophy is the same way. Well studied, again, documented. You take a tooth out and don't replace it. There's no physiologic stimulation within the bone itself. The bone atrophies, it shrinks, doesn't need to function, right? So it kind of melts down slowly over time. Some studies show you lose about 40% of that bone volume in the first year. Now, if you put a denture on it, that accelerates it, because now that's not non-physiologic pressure on that bone. If you put a dental implant in that area, now it's being stimulated by that function of chewing, bone is actually preserved. It's used sometimes, especially for denture patients, to avoid rapid accelerated bone loss. You put the two implants and then put an overdenture. That'll preserve the bone from actually, being lost so quickly. Again, no risk of decay there, minimal impact on adjacent teeth. You don't ground the adjacent teeth. However, the bridge could be a little bit less expensive initially, quicker replacement, no surgery required. They both function very well. Spoke about that. Dental implants versus dentures. It's not versus dentures, but if you get a denture only, they don't stay as well. People come in over time, you lose more bone. They become even more unstable. You get to a situation where sometimes you can't even put implants anymore because they lost so much bone. The best strategy is, put some implants. 2 or 4 is the more common design. Certainly for the lower, more than the top. The top has the palate, tends to give it more suction cup stability. The lowers usually tend to, move more because the floor of the mouth and the tongue. But that's one of the supportive things for dental implants, with combination of dentures versus not. Natural look, natural feel, of course. I don't recall anyone coming through my office in 25 years and say, God, I love dentures. I just want to have a denture. I mean, I have a ton of money, but I want dentures. I don't want implants. It usually is not that. To be honest, it's unfortunate. Most people want fixed teeth in their mouth. They want to feel good. They want to speak well. They want to feel the confidence. They want to be able to taste their food. No one that I know that comes in and is not aware of, hey, is a denture better than dental implants or not? I find that over 99% of the time, more than 99.9% of the time, it's people that don't go the implant route. It's people that cannot afford the potentially expensive treatment that comes along with a full set of teeth that is fixed. There are a lot of options, of course. It doesn't have to be A or Z. There's, everything in between. Preoperative assessment, again, every patient that comes in, this is a surgical practice. You come in and you should have that surgical practice assessment. It shouldn't be like, hey, just a little dental x-ray. All right, let's go drill. It's not a Home Depot project. This is surgery. So you have to go through your medical history, assess, any systematic disease, uncontrolled. What medications are you taking? How does that interact with your procedure? How does that, we spoke about those components earlier on in surgery. But you take a complete medical history, you take a complete medications history and allergies, you do a good clinical examination, and then we start with imaging. And again, 30 years ago, it used to take just a panoramic X-ray and good clinical exam, and we did it, and we did it well. But today you have 3D cone beam scans. Every surgical office has it. I mean, I believe it is the standard of care today. A cone beam scan shouldn't necessarily be done for every single implant, but a lot of times it is necessary if you have vital structures close by, like a nerve that runs into the lower jaw, or if you have a sinus on the upper jaw. How close are you? Because you want to avoid perforation into the sinus, or drilling into a nerve and cause a complicated surgical complication, of course. And you want to make sure that your bone doesn't have any pathology and you have good bone volume for it. That's what we're talking about. This is a panoramic X-ray. This patient, by the way, that's not my implant. But this patient came in for a consultation of wisdom teeth. But a panoramic X-ray is not a three-dimensional. A lot of people think it's three-dimensional because the machine rotates around their head. No, it's the machine rotates around your head to take a panoramic view. It's a two-dimensional. Three-dimensional image looks like this guy here, where you have three-dimensional rendering model. You can toggle, turn around, and then you can look at cross sections in axial views, sagittal views, coronal views, or panoramic. So you can look at it from 360 degrees in any area and find a lot of detail that definitely makes you gives you a better diagnosis tool and ability to plan your case accordingly. Surgical procedure is not that complicated, so this could be done under local anesthetic. Patients who are anxious can have sedation. But most of the time it can be done, and it's done under local anesthetic, where you go, the patient gets numb, the area is anesthetized. Let's say we're doing a single implant for a moment, just to keep things simple. It's a very minimal stab incision that 99.9% of the time you're not going to need even sutures for it. So rarely do we lay a big flap like we used to do in the past to see the bone, because we have the advent of the 3D imaging, and you know exactly where the bone is. Some people use even guided surgery for that. You use surgical guides, feel more comfortable with that. Some people do robotic surgery too with that, and you know where your bone is. You design the surgery on a computer and 3D rendering, and then you go ahead and execute. Again, the overwhelming cases, you don't even make an appreciable incision. You drill into the bone, you put your implant in. It's about 7 to 10 minutes if you're taking your time, and you should take your time. And then you place a healing abutment on top to mold the tissue around it, and you're done. You don't need stitches. If you do, they'll usually be the kind that dissolves on its own. Take 1,000 patients, get a single implant done, and come back and, hey, give me a survey. How bad was your pain after surgery? I'll probably come back and say it was a 3, 4 out of 10. I took Advil for it for a couple of days, Tylenol, and I was fine. Antibiotic coverage is, in my opinion, favorable. It's a topic of discussion, of course, in the medical world. 50% believe in it, 50% don't. But a failure is about 7%, not a failure, a chance of infection in oral surgery across the board in any oral surgery you do is about 7%. Short course of antibiotics, sometimes one dose pre-surgery is sufficient to reduce that chance by a lot. Some people wait until we have an infection and then do antibiotics, but if an implant gets infected, you got to take it out and start all over again. But usually, success rate is 90, 99, 98% easily. Once the implant is placed, you allow the patient a period of 2 to 3 months of healing. In the lower jaw, the bone is more dense, it heals better, faster. The upper jaw, especially in the back teeth, it takes a little longer, especially if you're doing any sinus lifting procedure to build up bone. You wait maybe 4 to 6 months with that. And then once it's healed, the surgeon tests the integrity of the implant with a torque wrench. It's an implant calibrated torque wrench. It doesn't come from a car. It's calibrated to 32 to 35 newtons per centimeter. The implant is solid. The X-ray looks like you have good bone integration. Then the patient goes to the dentist. The dentist will take a mold. They'll make a crown, install it, adjust the bite, and you're done. Post-operative care, people ask like, hey, any restrictions? And the answer is no. You can go ahead and eat usually normally. Stay away from the surgery side a little bit so you're not uncomfortable. But either the implant has initial stability, which it does most of the time, and then you can eat. Don't chew caramels and hard Italian bread on it right away. But if you're having your pasta and fish and scrambled eggs and pancakes, etc., that's all okay to chew on the side of the implant. Resume physical activities next day. I would say take the day easy, but next day hit the ground running, no problem. Osseointegration period we spoke about, the abutment placement we spoke about, the crown attachment we spoke about. I just want to be respectful for your time as well and not be redundant. So we spoke about immediate post-operative care, but afterwards, I used to say to my patients, you can eat on it anything you want, and I kind of changed that a little bit. It's really hard to believe, but I had a patient once, and he left it off. Honestly, it was really good spirit, but it's like, hey, I was opening a beer bottle with like, you don't do that with your natural teeth. Why would you do it with an implant? He thought this thing is titanium. Like, what are we like watching the villain in James Bond? Uh, Long story short, you can eat on it anything you would eat normally on your natural teeth. Please don't overuse it, overload it. You can break the crown, you can cause yourself harm. So brush it, floss it. Water pick is huge, in my opinion. You should be instituted into any oral hygiene, especially if you have implants. Go to your dentist routinely, 2 to 3 times a year, whatever they dictate based on your gum health, to maintain your natural teeth and your implant as well. Any discomfort you feel afterwards, anything unusual, I think it's always prudent to go back to your dentist and say, hey, can you check, take an x-ray? And if there's an issue, they'll send you back to your surgeon and see what can be done to rectify that. We spoke about follow-up visits, usually the surgery, and then you come, a week, 2 weeks later, anytime sooner if needed. And then, the 2 to 3 months test, and then you're done. You do your follow-up with your normal hygienist and your dentist. Common risk, again, we spoke about infection. Implant failure as a mechanical failure, like implant breaking itself, is rare. It is very, very rare. But can you lose bone around it? Yes, if you don't maintain proper hygiene. Nerve damage, sinus problems, aesthetic issues are usually related to the anatomy and the skill of the surgeon itself. Gum recession is a natural thing that happens around all your natural teeth. So yes, it could happen around your implant years later. And overloading is if the dentist doesn't do their job right, but there's no reason to believe that is the case. Sometimes it happens. Managing complications, that's a lecture on its own. I want to leave some room for asking questions as well. Success rate, we spoke about a solid 98% on the lower jaw, 95% on the upper jaw. Factors influencing that, we said your hygiene, your habits, your medical history, your bone density and bone availability. 20 years easy if you care for it. These are some references, and I just wanted to make sure we get to the Q&A before 8 o'clock.
Yeah, thank you.
Thank you, Rachel. Thank you guys for attending. I'm happy to answer any questions.
Yeah, there's a few questions.
Yeah.
One question is, why would an oral surgeon use a cadaver bone instead of titanium for an upper jaw implant after a tooth extraction?
The question is not clear. So
I guess why did they use a cadaver bone?
Right. So let's stick with that for a moment. Bone grafting, again, that's a really a great topic. I love bone grafting. I do bone grafting every single day. Bone grafting and the material used is predicated on why are you grafting? What's the purpose for the grafting? But I guess for the question is coming from, hey, I had a tooth taken out. My surgeon says, hey, I want to use bone, and it usually comes from a donor. Mm-hmm. Can I have my own bone harvested and placed there? The answer is yes, you can. However, it's a lot more laborious, and then more surgery, and then more complications, and more cost, and more time consuming to achieve the same result. However, let's say somebody comes in with a car accident, missing bone in their front teeth. There are limitations to what cadaver bone can do. And then you would actually go and harvest bone from the patient themselves and, transplant it into that area. So bone cadaver for uh, bone cadaver for grafting sockets after an extraction is the more common practice. It's safe. I mean, there's a lot of bone grafting companies, and you'd have to really buy from a reputable bank. I personally I go with, again, Zimmer, give me a shout out twice here today. It is the most reputable graft. It's the largest orthopedic company. They have sold 80 million grafts. We go with that. Zero cross contamination or infections. So it's got a great track record. They work well. Their sterilization process is really spotless, pristine. It's a multi-billion-dollar company. We get salespeople from local banks, and it's a startup, and it's half the price that come to the front desk and like, hey, can I meet the doctor? I'm like, you know what? I'm not interested. I want to know that I can use this to work. Now, on grafting, if you're using a bone graft from a cadaver, I think it's the concept is like, oh my God, it's skeeved me out. You can use your own, but just know that that serves only as a conduit for your body to generate bone.
Yeah.
And over time, it's replaced with your own bone. So, people who are subject of studies, they came back a year later and they took cores of bones, and the surgeon put it on a microscope, and they found the patient's own bone replaced the graft completely. So it only serves as a scaffold for it, if that answers the question.
And so I'll ask maybe two more questions. It's because it's clock. Can you get an MRI after an implant?
Yes, it's made again of titanium MRIs. Usually, if you have iron, ferrous plate, would cause a lot of haze, or the magnetics off. Is titanium magnetic? It has a very poor magnetic properties. Yes, it's a poor thermoconductor as well. But people that put dental implants in, they can get MRIs. They don't set off the alarm at the airport. You can live your life normally, nobody would know. And you can get an MRI of the area itself as well. It doesn't cause, but the area immediately next to the implant, might have a little haze. But in general, let's say you're getting an MRI for the jaw, absolutely no issues at all.
And then the other question is a few questions here about the range of costs for an implant.
Pardon?
The range of cost for an implant.
I'm going to say, and believe it or not, it changes by zip code. And I say in Bergen County, it runs anywhere from $2,300 to $2,500. Insurance companies cover a good portion of it these days. Conventional dental insurance companies cover for a good portion of it, depending on the patient's plan. In addition to the dental implant, then you will have the abutment and the crown. And again, that ranges anywhere between $2,000 to $2,500. Again, depending on the dentist and the skill and the material and the lab they use. There's a lot of craftsmanship, and there's a lot of, time. So it's dentist dependent. It's not you're not buying a commodity, you're buying a service. You're not buying the actual dental implant, you're buying the skill of a surgeon and a dentist to place and restore it as well. In addition to the lab material that's being used, in addition to the implants that are being used. The three implant companies we mentioned today, whether it's Straumann, Nobel, or Zimmer, most reputable, implant price. You could easily find dental implants as a dentist and buy for 20% the price. I mean, it could be fifth the price. It usually is not reflected, and differently to the patient's charge, but sometimes people cut their overhead a lot. But then what you're not getting with that is the tremendous R&D and support behind a reputable company, Versicon.
Well, thank you so much, Dr. Zaker.
My pleasure, Rachel.